I'm Dr. Yang. I'm from Taiwan, and today I was invited to gonna introduce some cases of my personal experience about the elong catheter, microcatheter use. So I choose the present 1 year which I performed the retrograde with elong microcatheter, and allow me to introduce the elong microcatheter first. And we all know this as a APT medical product, just mentioned before, as my colleagues mentioned before. And we know we use the microcatheter for increase the additional support for the guide wire when we're doing the CTO. And then we exchange the guide wire with the microcatheter to provide the tip shape and about the lumen we rescue, and then we prevent the guide wire to be entrapped to the other vessel with the CTO guide wire, and then we can perform the tip injection. And there is also we can, when we perform the CTO, we might create some wire bias, and then we can put in a coil, or sometimes we perform the fat embolism to stop the bleeding from the wire bias. And there is two major type about microcatheter for in the APT medical. And the first one is the strap tip, and the second one is the taper tip. And as we know, we all familiar about the Asahi microcatheter and the Terumo microcatheter. I think one is like fine cross, and the other one is like Cosell. It's the same using, but there's something different. The elong microcatheter is the first one is he have two sizes, and the one is 1.7 and the other one is 1.9. And the special difference is the mesh between the tip to the marker, and it's long for about 1 and 1.5 centimeter. It will provide a better mesh about a stainless. So it's provide I think I personally feel it's the provide better penetration power than fine cross. So here later I will show some cases. And then the elong microcatheter has some special designs about different markers. Here it has 1 marker, 2 marker, or 3 markers. It can help you to locate where you are when you go to a retrograde, and it will provide how about a distance when you should advance, and then you should change the other view for when you intervention the CTO. And I think this is just mentioned before, and it have all kind of sizes, and it's allow the 0.14 go easy to advance, and this is the taper. Taper we don't have this one in Taiwan, so I don't have the special experience about taper in the APT elong microcatheter. And this is some slide for about I think it's not important. I will go to the comparison about the microcatheter, about the strap tip to the compared to a fine cross. And then as you can see, the fine cross is a little bigger in the proximal. So just the colleague mentioned before, if we're gonna perform this with the Volcano IVAS, you got problem in the 7th French. So if you have to use the Boston IVAS with the fine cross to perform the IVAS guide penetration. And then in Taiwan, we sometimes use we call slipstream, which a technique invented by the Japanese doctor. We use the 7th French, and we use the IVAS, Boston IVAS. We use the Sasuke, and then we perform in the same time to in the same hose wire go to the side branch, and we locate where is the proximal cap for penetration. We call it slipstream. And then when we locate it, we can cross the stiff wire from the Sasuke in the same workhorse wire, so it can provide more easy and real-time penetration for the IVAS intervention. And then this is the other comparison. And as I mentioned, I did, because I didn't have experience about it, so I don't have the case about this one. And this is my first case about we using the Elong microcatheter. Unfortunately, we all have the one marker Elong microcatheter, so you can tell the significant difference between the Ficros and the Elong microcatheter. But this one is like my first case used about the catheter, and you can see there's multiple lesion about this patient, and regarding to the LAD CTO, we cannot identify where is the location, just like the colleague mentioned the similar case before. And if you take a close look, you cannot understand where is the where is the stump from the LAD, and then the diagonal is not the origin, maybe from here or maybe from somewhere else. So we just use the 7 French guiding tool and with the Elong microcatheter, of course, the IVAS, Boston IVAS, and then we put it back to locate the location, and then here is the Elong microcatheter, and then we perform a direct penetration, and across this is the IVAS guide for how to locate the penetration position where you are guiding with the diagonal branch. So when you locate it, you just penetration the tip, and then you cross the lesion easily, and then we check it for the retrograde, and then this is the final result for LAD. And this is case number 2. We have a 57 years old male, and is smoking, and he have a previous standing for the LAD, and then as you can see, the LAD stain was patent, and there's a epilateral retrograde from LAD to the circumflex, and here's the LAD RCA total stenosis, and you can see the CTO is over here, but I think this CTO is quite ambiguous, because in the first one we cannot identify which is the true root about this vessel, and sometimes the RCA might be looking like this, and the RCA and sometimes RCA always have different morphology. So if you gonna intervention the RCA, you have to think twice, and might be take care about the true lumen or its root in the natural root look like. So there is another problem in our patient. Is the retrograde reveal there is another tortuous point in the distal RCA. So we are going to taking a close look about this, and we guess there is some root in the close review, and we can see there's a long track between these two eyelets, and then according to this result, we go to check the retrograde first. And right now, if I see after the first experience about Elong microcatheter, if I see the patient have the collateral vessel like this, is more straight in the septal, I always choose the Elong microcatheter first, because I think it's more easier crossbore with compared with Ficros. and then we perform the retrograde because the standing, so we perform the septal branch stand opening first, and then we cross the microcatheter, and then we go back to the hold back to the distal RCA cap, and then RCA cap simply cross, and then we advance the other anti-gray microcatheter, and then it's perform a marker for these two shorten distance. And after this shorten, we just check these two distance. And as I just mentioned before, there might be many tortures in this vessel. So we just decide to advance the other anti-gray wire again, and then it's still ambiguous about these two vessels, and even the retrograde Gaia 3 cannot easily advance to the distal proximal cap about the RCA. So after the serious attempt, we found there is a bias about our anti-gray microcatheter, because the anti-gray microcatheter is located over here. But this is another branch. I think it might be a many collateral bridge here, so you cannot truly tell where is the actual root in this case. So finally, we retrieve the long microcatheter, and then we advanced the 1.9 French, which was a little bigger in the tip. It's allowed 0.17 wire size, and then we choose the random woods to cross the long microcatheter, and then we do the externalization here, and then we check the IVAS, and it's all in the true lumen. So this is the final result about our RCA and the LAD finals. And here comes the case number 3. This is also a CAD patient, and it just came to our clinic. And as you can see, there is stumpless LAD CTO. And if I may play again, and it's give a high collateral upper to the maybe this one is better. Upper to the diagonal branch. You can see there is a diagonal branch in the LAD cap. And in the first, we use the IVAS guide to choose to penetration this, and we use the XTA to advance this. But as you can see, the XTA cannot cross easily because the sharp angle we unable to cross. So in this moment, we decide to use to check the retrograde first, and then after we choose the retrograde, we found there is a root and quite clear for the retrograde. So sorry about a slide because the movie doesn't run. And then after we advance the retrograde wire up to the diagonal and the septal branch, and we can see there is a nice showing the tip injection by tip injection about the LAD distal cap, and previous there's Dr. Gao in Taiwan. He have developed some theory about the retrograde, and he created a name we call the length of penetration, because when you advance back to the microcatheter to here, you have to have some actual power to create length about here to penetration up to the proximal the CTO body. But this case is unfortunate. This case is have no coaxial for the penetration about this CTO body. So we after we use the stiff guide wire to try, we have decided to integrate again, and then this time we choose the stiff wire, and this time we have the better guide of the true lumen. So we use the Conquest Pro, and then we just penetration directly to the distal LAD, and then finally we create a actual after standing we rescue the CTO, and this is the case number. This is the case number 4, and this one is also the a failure case referred by my colleague back in Taiwan. And then in the first, literally in the 2008, with unstable engine, literally with 2 stents. One stent was here, and in the LAD, and the other stent it was in the RCA. And then this patient is come back to 2020, and then is BCER with the syncope episode, and then they found the short-run ventricular tachycardia, and then the complete AV broke, all kinds of the bradycardia in the ER, and then after the his symptom relief after the ICD implantation, and then he came back with chest pain and syncope again in 2021, and then they finally referred to me about this case, and I go to check the CAG first, and then you can see there is a instant near total occlusion in the RCA proximal distal part, and initially I tried the antigrade, and I think the most instant restenosis can try the antigrade attempt, and with success. But in this case, I failed because I think the major problem is when I advance the antigrade wire a little too quick, and then after I check in the other view for the LAD CTO, RCA CTO, I found there is a stent just crossed up to here, and my antigrade wire, it was smooth tear here, and then while I wanna engage the real CTO body about the red part, I just go to the fourth lumen, and then this is unrescuable. I cannot recross the real side again. So I check the retrograde route again, and then I use the longer elonged microcatheter with broken Sion, and then broken tip Sion, and then fortunately, I crossed the broken tip Sion to hit to the CTO body, post-stent CTO body, and then this wire is come closer and closer, but I still cannot give the same enough close, and I cannot get real externalization because I think the CTO body is included into the instant restenosis. So finally, I performed a contemporary reverse cut, and then finally I go back to the whole wire can advance to the proximal RCA CTO body, and then we find this is the final result about this case, and I think I preserved most of vessel, but when I check IVAS, there's some hematoma also present here. So this case was followed after 1 month after 1 month, and the vessel is okay right now. And this is case 5. I go quick. This is the other case. This case is a woman who was admitted for cholecystitis, and then when she went for the anesthesia for for the basic physical exam. They found he have some special presentation in the ECG, and then they asked me to perform the exam for about CAG, and then I do the CAG, and as you can see, there's almost triple vessel, left ventricle vessel, almost a KBG indication for this case. So initially, we can see the RCA was just a tip. And this one is the RCA, the left side predominant case. So initially, I think the RCA might be not quite difficult, because I think RCA should be crossed easy by Gaia first. And I was wrong. The Gaia first went for the fourth lumen quickly, and in the end of the vessel, because this is not a regular RCA, so I don't see. I underestimate this case will be show different route about the RCA. So after this, I decide to try the Elon microcatheter again, and then I go back from the septal branch to the distal RCA, and then this is the chosen about the Elon microcatheter, and then when we advance the Elon microcatheter with SU003, it's quite easy to recross the whole section, and then the Elon microcatheter can provide a better support about the retrograde. So finally, I got easy to advance the proximal cap about RCA, and then after standing, the result was good. And we also fixed the left side either, and then this is treated with the DK crush. Then patient go for her surgery about 2 months later, and then she was quite well right now, about 2 years, and then she also have a happy life right now. This is the other case which I made before, and you can see there's long RCA proximal cap, and then if you advance with the Elon microcatheter about the retro route, and then I think the most powerful microcatheter, not taper end, is about Elon 1.7. Because this one is provide you a better support here, and then we switch the stiff wire, and then we direct puncture to the RCA opening, and then you can see RCA after we puncture to the RCA point opening, we just check the contralateral image, and then finally we cure this case either. So in my conclusion, the Elon microcatheter provide a better support compared to the fine cross. I think it's more easy, give you the direction of power. But if you need to cross some vessel, it's so tortuous. I think my fine cross should be the first choice of the very tortuous vessel, and the straight collateral should be the Elon microcatheter was for the straight collateral branch. Okay, thank you. 1.7. When I use
170.
I think
millimeter, 170 centimeter microcatheter. Okay.
Yes.
Or 160. What kind of guide wires do you use? Because I tried once. And the length of the guide wire is 180, so you have just 10 centimeters to maneuver. So it means that you are using long guide wires?
Sometimes I use the Abbott, because
extension,
Abbott,
you mean?
No, Abbott, the Versatton. Abbott is a little longer wire, about 190 centimeter. And then you will select after he select the branch where you want to go, you can, I still change back to the seal breaking tip Sion or something. But I not experience very difficult about the length about the wire, because it's always always give the when you advance to the collateral, it still have some shortening about the collateral. The microcapacitor become some shortening, so the wire is not too bad to manipulate. Yes.
And the second point is I am only using the 2.6 tapered E-long. So it is the only one you are not using. Yeah.
It's not available in Taiwan.
So not available in Taiwan.
Yeah.
Okay, because for me it's one of the best. Because the other are like more or less than the fine cross, but the other one is more or less it's a in between Corsair Pro and Turnpike Spiral, and it's not the spiral like the Turnpike spirals. It means that the external spire are not so visible, but there is internal. So to go through some very tortuous collateral, it's one of the best. Like the Corsair Pro was named after septal dilatator, and it's the same size with the Corsair Pro, and this one is really, really good. So you might try to have it in Taiwan.
Sure.
Yeah, I have to commend and great cases and congratulations about presentation. You nicely showed about IVUS utilization. Even though you use Boston, it is possible with Volcano. I was also with that. And I just wanted to mention also, like Alexander told, I'm using E-long few times, used 1.7 in epicardial, very long, fragile epicardial tortuous collaterals. It's very nice. It's very passively moving off the wire. So, but we have to be careful about 170. I just wanted to say the same question, because if you have a microcatheter and you have also Y connector and sometimes we use the microcatheter E-long. There was some case and some wire Confianza Pro Fielder FC nowadays C on blue is 180. So Fielder FC, we pushed Fielder FC inside and wire didn't go out. So it was too short, and it's now C on blue. In the future will be all will be 190, and it's important to say, for example, Gladius EX is, if you use retrograde 170 centimeters, it's nice to know that you have to have Gladius EX, which is 200. And interesting, all Teleflex new wires, Bandit, Raider, Warrior, they are all 200 centimeters and 300. So they're completely with E-long 170. Also, I'm using on the anterograde cases, calcific cases where I need support, of course, 2.6 French version. It's very nice, it's very torqueable, it's very supportive. But because you don't have it in Taiwan, how is your experience with support? I did some nice cases, and how you feel support with 1.7 anterogradely.
You mean the support antegrade?
Is the support enough with this very tiny microcatheter for those cases, or you had lack of support, but you managed to deal with that with some techniques?
Sometimes when you advance in especially the RCA, you have to use, like Dr. Santoso just mentioned, the extension microcatheter to perform better support, because as RCA opening is always tortuous, and then if just the last case the tip is even did not show any landing spar for the guiding catheter, sometimes I will use the antegrade wire to go a little advanced, and then I will perform the extension microcatheter to elongate the guiding catheter, and then let the backside sitting in front.
To use the other support techniques.
Yes.
And